Good evening. Am I audible and visible? If I'm audible and visible, can I get a quick nod, please? Hi, Fatih Zahir. Hi, Vishal Meghani. Yeah, thank you. So I'm sorry for the delay in the beginning of the session. Yesterday's session PDF. Yes, I will share it, Paul. I will share it after this session. So I'm sorry for the delay in the beginning. Yeah. So there was a technical glitch. I was not able to connect my camera to the OBS studio. So now that it is sorted out, let's start the session. So this is part 5 of NEET PG 2023 and FMGE Biochem Pearl series. In this session, I will be discussing few facts and concepts related to mucopolysaccharides, few concepts related to genetics and about alcohol metabolism, and few MCQs on carbohydrate metabolism. So by the end of the session, you would have learnt lots of facts and concepts in biochemistry. Yeah. So with that assurance, good evening, Ruben Stanley. So with that assurance given to you, let me start the session. First, let me tell you what Unacademy has got as a plans for you. So the good news is for 2023, for the beginning of 2023, there is a 23% off on all Unacademy Medical PG subscriptions. And to avail this offer, you can use any educator's code. If you want, you can use my code, which is Shanmugapriya. And what is shown here is the offer price that is available for you. So for 36 months, the cost that you will have to pay is just 18,480. And then currently, as I told you, hi, good evening, Shivangi Chatterjee. Hi, Akhtar. So as I told you yesterday, now we have released recorded sessions also on Unacademy platform. So till some time back, it was just live sessions. So now you'll be able to access even recorded sessions, and this is available as PG Vital subscription. So there are 3 options which are available. You can just get PG Vital subscription or live subscription, or you can use it as a combo package where you'll be able to access both recorded sessions and live sessions. And what is happening live currently? So currently we have final summit batch for NEET PG 2023 aspirants, and module 1 is emergency room, wherein we discuss usually all case based MCQs. So even in biochemistry, we were discussing liver function test, renal function test. I told you about how to interpret arterial blood gas analysis reports, and thyroid function test. And we also have a module 2, which would include frequently forgotten volatile topics. And module 3 would be most expected questions, wherein previous year questions will all be discussed. So this will be available as live sessions. And apart from this, as I told you, biochemistry is also available as recorded sessions. And for all these subscriptions, you can use any educator's code. Good evening, Ashi. So this is the first question for today. A young patient presents with colon cancer. He is diagnosed with hereditary non-polyposis colon cancer. The most common DNA repair mechanism defect causative of this condition is. So I think we have already discussed this DNA repair mechanism which causes hereditary non-polyposis colon cancer. How many C's do you find here? 2C, and it is caused by a defect of 2M. What is 2M? Mismatch repair. So hereditary non-polyposis colon cancer, otherwise called as Lynch syndrome, is caused by the defect of mismatch repair. And the most common mutation causative of hereditary non-polyposis colon cancer is human mutant S homology 2. Yeah, human mutant S homology 2 mutation causes HNPCC. It is associated with microsatellite instability as well. With this as a background, let's try to understand the various repair mechanisms and the disorders which are related to defects of those repair mechanisms. So there are 4 repair mechanisms that I want you all to learn about. The most common repair mechanism that happens is nucleotide excision repair. Yeah, or we can start with base excision repair. What is base excision repair? In this case, the backbone of the DNA is maintained normally, only the base gets lost. You know, the base will be A and T or G and C. So the backbone is maintained normally. For any reason, if the base gets lost, that is called as base excision, and the repair is done by apurinic or aprimidinic endonuclease. Don't you think it's a logical name? If a purine is lost, it's a apurinic site. If a pyrimidine is lost, it's a apyrimidinic site. So the enzyme is apurinic or apyrimidinic endonuclease. So that is base excision repair mechanism. And the second one is mismatch repair mechanism. And the third one is nucleotide excision repair. And finally, double-stranded DNA break repair. Out of these 4 repair mechanisms, which repair mechanism I told you is very common? It is base excision repair, which is very common, because base excision error is the most common error that can happen in a DNA. Now about mismatch repair, what did I tell you about this? Yes, Lynch syndrome, you're right. So what did I tell you about mismatch repair? It has got 2 M's. And mismatch repair defect causes 2C. What is 2C? Hereditary non-polyposis colon cancer. Nucleotide excision repair defect. Excision has got X. So excision repair defect causes X, xeroderma pigmentosa. Okay. Double-stranded DNA break repair defect causes ABF disorders. What is ABF disorder? A stands for ataxia telangiectasia. B stands for Bloom syndrome. F stands for Fanconi's anemia. So have you all memorized this list? Is it not very simple? So which is the most common error that happens in a DNA? It is base excision error. And mismatch error defect. Yeah, mismatch repair defect causes hereditary non-polyposis colon cancer. Nucleotide excision repair defect causes xeroderma pigmentosa. Double-stranded DNA break repair defect causes ABF disorders. ABF is ataxia telangiectasia, Bloom syndrome and Fanconi's anemia. Okay. So the next question. All the following are components of mucopolysaccharides except. So yesterday some of you were asking me to discuss about structure of mucopolysaccharide. So today I will be discussing for the next 10 minutes about mucopolysaccharide structure, about mucopolysaccharidosis, and if an image based question is asked related to mucopolysaccharide, how to identify the structure. Yeah, for the next 10 minutes we are going to discuss this. So watch this 10 minutes carefully for you to be able to answer any question on mucopolysaccharide, because mucopolysaccharide is a favorite topic for NEET PG as well as FMGE. So what is the right answer here, all of you? All of the following are components of mucopolysaccharides except. The answer is N-acetyluramic acid, because N-acetyluramic acid is a component of glycolipids. As I told you yesterday, it's a component of gangliosides. So let's try to understand the structure of mucopolysaccharide. The first fact about mucopolysaccharide is that they are all heteropolysaccharides. And all mucopolysaccharides. So I'm going to now tell you 3 thumb rules and its exceptions. Yeah, 3 thumb rules and its exceptions. If you remember these thumb rules and exceptions, you will be able to answer all questions related to mucopolysaccharides. So the first thumb rule is definition of mucopolysaccharide. All mucopolysaccharides are long, straight, unbranched chains. They are all long, straight, unbranched chains containing repetitive units of uronic acid and amino sugar. That is, if the first one is uronic acid, the next one is amino sugar. So are you clear about this? All mucopolysaccharides are long, straight, unbranched chains containing repetitive units of uronic acid and amino sugar. Now there is an exception to this rule. There is one mucopolysaccharide which does not have uronic acid at all. Instead of uronic acid, it has got only galactose, and that is keratin sulfate. So if you are asked which mucopolysaccharide does not have uronic acid, what will be your answer? Your answer should be keratin sulfate. If they ask you which mucopolysaccharide has got galactose, your answer should be again keratin sulfate. That is the first thumb rule and its exception. Now second exception is, when I say they have uronic acid, I mean to say they all prefer to have glucuronic acid. Yeah, what do I mean to say? I mean to say it has got glucuronic acid. The exception is, instead of glucuronic acid, eduronic acid. Yeah, instead of glucuronic acid, eduronic acid is present in heparin, heparin sulfate and dermatan sulfate. Okay, instead of glucuronic acid, eduronic acid is present in heparin, heparin sulfate and dermatan sulfate. If you're asking me how do I memorize it, it's easy to remember. Yeah, how do we inject heparin most commonly? Can you all type it in the chat box? How do you inject heparin most commonly? We inject heparin most commonly subcutaneously. So one who injects heparin intradermally is an idiot. Do you understand this? One who injects heparin, no offenses, just for remembrance. Yeah, one who injects heparin intradermally is an idiot. So heparin, heparin sulfate and dermatan sulfate have what? They have eduronic acid. Okay. Now the third thumb rule is, when I say they prefer to have amino sugar, I mean to say they all have glucosamine. What amino sugar do they prefer to have? They prefer to have glucosamine. Exception is, instead of glucosamine, galactosamine. Yeah, instead of glucosamine, galactosamine is present in chondroitin sulfate and dermatan sulfate. Instead of glucosamine, galactosamine is present in chondroitin sulfate and dermatan sulfate. How do we remember this? I hope you will all agree with me if I say, the fashion throughout galaxy now is to look skins and bones. Yes or no? The fashion throughout galaxy now is to look skins and bones. You know, size zero's fashion now. Okay. So have that in mind. Fashion throughout galaxy, galactosamine is to look skins and bones. For skins, remember dermatan sulfate. For bones, you remember chondroitin sulfate. So have you memorized these three thumb rules and the exceptions? So I am going to write down all these thumb rules and exceptions here. So what did I tell you about all mucopolysaccharides? I said all mucopolysaccharides are long, straight, unbranched chains containing repetitive units of uronic acid and amino sugar. What is the first exception? There is one mucopolysaccharide which does not have uronic acid. Instead, it has got galactose. Which mucopolysaccharide is it? I want the chat box to be active, please. Which mucopolysaccharide has got galactose? It is keratin sulfate. Now the next thumb rule, all mucopolysaccharides, yes, heparin sulfate, heparin, when I say they have eduronic acid, it does not mean all of them are eduronic acid. Do you understand this? Even in heparin and heparin sulfate, there is glucuronic acid, but additionally they also have eduronic acid. That is what we mean by the statement. Do you all understand this? Good. Yeah, so the second thumb rule is they all prefer to have glucuronic acid, but the exception is, instead of glucuronic acid, eduronic acid is present in heparin, heparin sulfate and dermatan sulfate. Now third thumb rule, all these mucopolysaccharides prefer to have glucosamine. Exception is galactosamine, fashion throughout galaxies to look skins and bones. Galactosamine is present in chondroitin sulfate and dermatan sulfate. Okay, good. Yes, you are right, Dr. Bean. So before I tell you about that, the last thumb rule is, all these mucopolysaccharides, apart from uronic acid and amino sugar components, they prefer to get sulfated or acetylated so that they can carry negative charges. Apart from uronic acid and amino sugar, which will form the backbone, they additionally prefer to get sulfated or acetylated so that they can carry negative charges. Exception is, there is one mucopolysaccharide which is neither sulfated nor acetylated, and that is hyaluronic acid. So hyaluronic acid is neither sulfated nor acetylated. So to summarize, you forget about the last thumb rule and exception, which is just an additional factor. Okay, so forget about the last thumb rule and exception. If you exclude that and if you consider the backbone, the one mucopolysaccharide which follows all the thumb rules, yeah, the one mucopolysaccharide which follows all the thumb rules is hyaluronic acid. Which means, what is hyaluronic acid made up of? Hyaluronic acid is made up of glucuronic acid and glucosamine. That is, it is very obedient. Hyaluronic acid is very obedient. It follows all the thumb rules. It is made up of glucuronic acid and glucosamine. And the one which is rebellious, yeah, which follows all exceptions, is dermatan sulfate. As answered by Dr. Bean, yes. The one mucopolysaccharide which comes under all the exceptions will be dermatan sulfate. So what does dermatan sulfate have? Dermatan sulfate has eduronic acid and galactosamine. Okay, dermatan sulfate has got eduronic acid and galactosamine. So have you understood all these facts about the structure of mucopolysaccharide? Yeah, will you be able to answer this now? Try to answer this. All the following are components of mucopolysaccharides except. Do they have uronic acid? Yes. Do they have amino sugar? Yes. Are they sulfated? Yes. So what is the right answer? The right answer here is N-acetyl nuraminic acid. And N-acetyl nuraminic acid is a component of ganglioside, about which I told you in the last session yesterday. Okay. Yes. The mucopolysaccharide with galactosis. Can I see answer from the chat box, please? Live chat, please be live. The mucopolysaccharide with galactosis, keratin sulfate. Very good. The mucopolysaccharide with glucuronic acid is very good. Bharat Rockbuster. Very good. Krishnendu. Good. Meningococcus. Paul. Good. So answer this question. The mucopolysaccharide with glucuronic acid is. So which mucopolysaccharide follows all thumb rules? It is hyaluronic acid. So answer is hyaluronic acid. Otherwise, you know, heparin sulfate and dermatan sulfate, they all have eduronic acid, and keratin sulfate does not have uronic acid. Instead, it has got galactose. Good. The mucopolysaccharide with glucosamine is. What is the right answer? Glucosamine. Again the same question. Which mucopolysaccharide follows all the thumb rules? It is hyaluronic acid. Now not only hyaluronic acid, even keratin sulfate can be the right answer here. So this is one MCQ with multiple right answers. Glucosamine is present in both hyaluronic acid and in keratin sulfate. Do you all agree with me? Yeah? Yes. Yes, Dr. Bean, you're right. So this is a case-based MCQ which is based on mucopolysaccharidosis, and I'll help you understand why I always say that biochemistry is not just a preclinical subject. It's actually a clinical subject, because you will not be able to make a diagnosis without having a biochemical understanding of the disorder. Okay, so though the question looks a very lengthier one, right? The stem is very lengthy with a very long case. Okay, so 8-month-old female child presented with flat nasal bridge. You know the answer already. Very good. Prince Davis says it's Hurler's. Yes, it is Hurler's because it is given as L-iduronidase activity being low. So if you have a good memory, you will know that L-iduronidase activity being low is nothing but Hurler's disease. But the question is, they have not asked you what is the disorder. They asked you which of the following would accumulate in this condition. Please discuss about complex carbohydrates, glycoproteins, glycolipids. Meet Patel, I discussed yesterday. Please watch yesterday's session. I will tell you about glycoproteins and proteoglycans now. Okay, I'll tell you after this question discussion. I'll tell you about glycoproteins and proteoglycans, and for you to know about glycolipids, I recommend that you watch yesterday's session. Yesterday at 7 o'clock, a live YouTube session was conducted. Please watch that. Okay, so so the question is, which mucopolysaccharide will accumulate here? So if iduronidase activity is low, iduronic acid will not be metabolized. Can you name mucopolysaccharides which have iduronic acid? Name mucopolysaccharides which have iduronic acid. One who injects heparin intradermally is an idiot. So heparin, heparin sulfate and dermatan sulfate, all these have iduronic acid. So if iduronidase is defective, these mucopolysaccharides will accumulate in the extracellular matrix. So in Hurler's and in Hunter's, Hunter's is caused by the defect of iduronate sulfatase. Yeah, Hunter's is caused by the defect of iduronate sulfatase. In both these conditions, what are the mucopolysaccharides that will accumulate? Heparin, heparin sulfate and dermatan sulfate will accumulate. Okay, so I am going to help you understand the differences between Hurler's and Hunter's now. Before we start that discussion, let me summarize what is provided in the history. There is a female child presenting with flat nasal bridge, big lips, macroglossia, gingival hypertrophy, abdominal distension, short stature, delayed milestones. On examination, there was organomegaly and inguinal hernia. Chest X-ray shows cardiomegaly, urinary mucopolysaccharides were elevated. Okay. Hunter's, yes, iduronate sulfatase defect. So I am going to fill up this tabular column. I want all of you to be active in the chat box. So the first difference between Hurler's and Hunter's is, which type is it? Hurler's is type 1, Hunter's is type 2. Which enzyme defect is causative of these conditions? Hurler's is caused by the defect of L-iduronidase. It is caused by the defect of L-iduronidase, whereas Hunter is caused by the defect of iduronate sulfatase. Yeah, iduronate sulfatase defect. Now, based on this understanding, can you tell me which condition will be very severe? If you look at Hunter's, it is only a defect of iduronate sulfatase, which means only those iduronates which are sulfated will not be metabolized, and that is going to account for very less number of iduronic acid in heparin sulfate and dermatan sulfate. So the metabolism is affected less, yeah, in the case of Hunter's, because it's only a defect of iduronate sulfatase, the metabolism that is affected is less, so it is going to be a less severe condition. So which is more severe? Hurler's is more severe, Hunter's is relatively milder. Now, what are the clinical features that you observe in both these conditions? It's very simple. Both are related to iduronate metabolism. And you know, iduronic acid is present in heparin sulfate and dermatan sulfate. So, in both these conditions, what are the two mucopolysaccharides that accumulate? Heparin sulfate and dermatan sulfate. Yesterday, I told you dermatan sulfate has got the widest distribution. You take any tissue, its extracellular matrix will have dermatan sulfate, right? So when dermatan sulfate accumulates, now it accumulates in the extracellular matrix of all the tissues. When it accumulates in connective tissue, it is responsible for gargoylism. Yeah, gargoylism is nothing but coarse facial features. What are the coarse facial features that you will observe? One is coarse facial features and then macroglossia. You will also observe macroglossia. And when this heparin sulfate and dermatan sulfate accumulates in connective tissue, it causes cartilage destruction. And this cartilage destruction is the reason for short stature, depressed nasal bridge. And when it accumulates in organs, that is responsible for organomegaly. That is why you find hepatosplenomegaly, cardiomegaly. And when there is hepatosplenomegaly and when subcutaneous tissue is also not very strong, because subcutaneous tissue strength is determined by how mucopolysaccharide turnover happens. And in this condition, because heparin sulfate and dermatan sulfate accumulate in abnormal fashion in subcutaneous tissue is not that strong. Along with that, when there is organomegaly, the abdomen gives way. And that is the reason for inguinal hernia. Okay, and when it accumulates in neuron, that causes nervous disability, and that is the reason for mild mental retardation. Yeah, in the history it was provided as mental retardation. That can also be retinal degeneration, and because it accumulates in cornea, there will be corneal clouding. Do you all understand this? There will also be corneal clouding. So what are the clinical features of Hurler's? So I want you to understand that in Hurler's, heparin sulfate and dermatan sulfate accumulate. Dermatan sulfate is accumulating in all tissues, extracellular matrix. When it accumulates in connective tissue, it causes coarse facial features with macroglossia, gingival hypertrophy. It causes cartilage destruction. That is why there is short stature, depressed nasal bridge. There is organomegaly, hepatosplenomegaly, cardiomegaly, inguinal hernia. When it accumulates in nerve, that causes mental retardation, retinal degeneration, and it accumulates in cornea, causing corneal clouding. Okay. Now, how about Hunter's? Hunter's, the feature will be almost the same gargoylism, same gingival hypertrophy, macroglossia, but inguinal hernia is not very common because it's relatively milder, and there is no corneal clouding. Yeah, no inguinal hernia and no corneal clouding. How can we remember it? Hunter's vision has to be perfect, right? For a hunter, vision has to be perfect. So hunter, there is no corneal clouding. Got it? Yes. And the last difference is inheritance. So tell me, what is the difference in terms of inheritance? For hurlers, it is autosomal recessive inheritance. In hunters, it is X-linked recessively inherited. Yeah, hunter is X-linked recessively inherited. So have you understood the differences? Hurlers is type 1, hunters is type 2. Can you all see me? Yeah. Yes. Hurlers is type 1, hunters is type 2. Hurlers, the enzyme defect is L-iduronidase, hunters is iduronate sulfatase defect. And severity, hurlers is more severe, hunters is milder. Clinical features, as I told you, almost very similar, except for the fact that, hi Kumbar, if I'm right, I think I'm pronouncing your name properly, Debadatta, hi, I'm happy. Yeah, so clinical features will be more severe in hurlers. In hunters, there is no corneal clouding and no inguinal hernia. Inheritance, hurlers is autosomal recessive, hunters is X-linked recessive. Okay. So what is the right answer here? The right answer here is accumulation of heparin sulfate. So as I told you, even if you know nothing about hurlers, nothing about hunters, what enzyme defect is responsible for these two conditions, just because you know iduronic acid is present in heparin sulfate and dermatan sulfate, you will be able to answer this question correctly, and that is why an understanding of biochemistry is essential. Okay. So this is an image based question. Identify the structure. Who wants to try this? Yeah, this was asked in INI-CET. Identify the structure. Thanks, Vignesh. So, can I start giving you clues to answer this? Krishnendu, please don't worry about it. It might look complex, but it's very simple to understand. I'll help you understand it. Where is part 1 to part 4 available? It's available online, live YouTube session. Just search as Biochem Pearls. You will be able to see it. NEET PG, FMGE and NEET PG 2023 Biochem Pearls. Okay. So Vignesh V thinks it's chondroitin sulfate. Vishal thinks, very good. Vishal is right. It is keratin sulfate. Yeah, Vishal is perfectly right. It is keratin sulfate. Very good, meningococcus. So I'll help you understand, I'll give you clues to answer such questions. Okay. So whenever such a structure is provided, I want you to check two structures. Yeah, one is you have to find out which is the acid part and which is the amino sugar part. So do you see a carboxyl group here? If there is a carboxyl group here, then that is the acid part. And do you see an so what is this? This is glucuronic acid. Is that clear? Is it stuck? All of you? Dr. Bean says it's stuck. Otherwise, Krishnendu, stuck, glitch. It's back? Okay. Thank you. So the first one is uronic acid. Are you clear about this? If the carboxyl group is above the plane of the ring, it is uronic acid. So the first one is uronic acid. Now in the amino sugar part, you should find out whether it is glucosamine or galactosamine. And those of you, if you had attended for those of you who have attended my session already on isomerism, I would have told you glucose and galactose are epimers at the 4th position. Yeah, glucose and galactose are epimers at the 4th position. So check the 4th carbon atom. In the 4th carbon atom, if OH lies below the plane of the ring, it is glucose. Very good, Dr. Rambo. So in the 4th carbon atom, if OH lies below the plane of the ring, it is glucose. So this is glucosamine. So it is uronic acid and glucosamine. So tell me which structure has got glucuronic acid and glucosamine. All of you tell me the answer. The one which follows all the thumb rules. Yeah, the one which follows all the thumb rules is hyaluronic acid. So this structure is hyaluronic acid. Got it? Very good. Now look at the next structure. Follow the same step. You have to follow 4 steps. So the first step is find out which is the acid part. So this is the acid part and this is the amino sugar part. Step number 2, in the acid part, find out where the carboxyl group is. The carboxyl group is above the plane of the ring, which means this is uronic acid. And in the amino sugar part, whether it is glucosamine or galactosamine is what you should find out. For which you should check the 4th carbon atom. In the 4th carbon atom, do you see that OH is above the plane of the ring? Yeah, OH is above the plane of the ring, which means it is galactosamine. So it is uronic acid, glucuronic acid plus galactosamine. What is the right answer? If it is glucuronic acid with galactosamine, I said galactose is present in chondroitin sulfate and dermatan sulfate. But dermatan sulfate will have eduronic acid. So what is it? It is chondroitin sulfate. Do you all understand this? It is chondroitin sulfate. Very good, Dr. Rambo. Meningococcus is not dermatan sulfate, because had it been dermatan sulfate, this should have been eduronic acid. Okay. The next structure. So have a look at this. Which is the acid part, all of you? The first one is the acid part. The second one is amino sugar part. And in the acid part, the carboxyl group is below the plane of the ring. If it's below the plane of the ring, what is it? It is eduronic acid. So it has got eduronic acid. And in the amino sugar part, check the 4th carbon atom. In the 4th carbon atom, OH group is above the plane of the ring. If OH is above the plane of the ring, it is galactosamine. Right? It is galactosamine. So which will have eduronic acid and galactosamine, something which follows both the exceptions, something which is very notorious, rebellious, it is dermatan sulfate. Right? So what is the identification here? It is dermatan sulfate. Very good. Now this will be the last structure. Check this structure. Do you find any acid part here? Do you see any acid part here? No. Had it been an acid, it should have been carboxyl group. This is not carboxyl group. So there is no acid at all. There is no uronic acid. Instead, it has got galactose. So which mucopolysaccharide has got galactose? It is keratin sulfate. Is it not simple now? Yeah, so this was the question which I showed you. This is an INI-CET question. So tell me, what is it? This has got no uronic acid. It has got galactose. So what is the structure? The structure is keratin sulfate. So if you spend some time, if you spend some time in understanding and learning, you will not go wrong, however tough the question is. Okay, you cannot be in a hurry. Please listen to me carefully. You cannot be in a hurry to establish something which has to be long lasting. Yes or no? Yeah, what I see these days is students are always in a hurry. In 1 hour, I want to learn 100 facts. In 1 hour, I have to learn 50 concepts. That is not how it works. It's not just about the number of facts or about the number of concepts that you learn. It is always about how retention, how good the retention is going to be and how well you will be able to apply it. And for you to be able to apply something, it should be higher order of thinking. And for you to establish higher order of thinking, you should spend some adequate time in learning every fact and every concept. So please don't always be in a hurry to establish something which has to be long lasting. Okay. Yeah, I know it is not that easy if you don't know these steps. I am happy that you have understood now, Dr. Bean. What can we do as we are time bound because of exam date? Yes. So this is what I want you all to know. There should be a balance. Yeah, you should strike a balance between spending time in understanding concept as well as in learning it in a time bound fashion. Okay, so always have a schedule for yourself. Within the schedule, how much ever you're able to learn, finish it. Okay, once your time for biochemistry is over, for example, every day you have decided to read for say 9 hours. Yeah, you have decided to read for 9 hours a day. So 9 hours for one day, you have decided to devote 4 hours for biochemistry. So in that 4 hours, if you are done with whatever you have read in biochemistry, close it and start the next subject. So I would say you should know, you should know something about everything. You should know something about everything in the sense all 19 subjects you should have a knowledge. so that any question that is asked, at least based on your basic knowledge that you have established, you will be able to exclude 2 choices. So please be mindful. Yeah, please cover all 19 subjects and then go and attend the exam. So have a schedule for yourself. Devote a fixed number of hours for every subject, and once the number of hours is over, don't worry about it. Yeah, just keep going ahead with the next subject. But what you should also do is you should keep writing grand tests. So as and when you write grand tests, you will be in touch with all 19 subjects, and all 19 subjects you know something about everything. Do you understand it? Yeah. So what is the right answer here? Identify the structure. So it is uronic acid again. Yeah, it is glucuronic acid, and this is the amino sugar part wherein OH group is above the plane of the ring. So it is galactosamine. Glucuronic acid plus galactosamine is chondroitin sulfate. Good. So that's all about mucopolysaccharide and mucopolysaccharidosis. Let's try to change topics now. So this is a topic which is frequently asked in NEET PG as well as in FMG. That is why I thought I should definitely discuss about it. So this is about alcohol metabolism, and I'm going to use this MCQ to help you understand all about alcohol and alcohol effects. Okay. So 55-year-old. So somebody has answered it as choice A. Who has answered it? Prince Davis, Dr. Bean, Vishal. Meningococcus has answered it as high NAD. Most of you have answered it as thiamine deficiency. I know. Yeah, you're not alone if you have chosen it as thiamine deficiency. Many students tend to choose it as thiamine deficiency. But take it from me, yes, thiamine deficiency is one of the manifestations of alcoholism, but that does not explain hypoglycemia. Do you understand this? That is not the explanation for hypoglycemia which is observed in alcoholism. So the reason for hypoglycemia in alcoholism is low pyruvate and low oxaloacetate. Do you all know that pyruvate and oxaloacetate are the first and the second intermediates of gluconeogenesis? Yeah, gluconeogenesis is reversal of glycolysis. In glycolysis, you start with glucose, you split it into 2 pyruvate. In gluconeogenesis, you start with pyruvate, you build it to one form of glucose. Yeah, you build it to form one molecule of glucose. So in alcoholism, when there is low pyruvate and low oxaloacetate, gluconeogenesis cannot happen, and that is the explanation for hypoglycemia. I am going to tell you why now. Watch this carefully. You don't have to be confused, Dr. B. That is why you should not learn facts in bits and pieces. Yeah, you should comprehend everything, understand and learn. Okay. So you are going to understand everything now. How is alcohol metabolized? You know, alcohol is always represented as RCH2OH, and any alcohol, be it methanol or ethanol or ethylene glycol, all these will be utilized or metabolized by alcohol dehydrogenase. And this alcohol dehydrogenase removes hydrogen atoms and converts this alcohol into an aldehyde. And then aldehyde dehydrogenase acts on this aldehyde, converts it into an acid. And both these dehydrogenases remove hydrogen, will give those hydrogen atoms to its coenzyme which is NAD, that gets converted to NADH. So a metabolic status, the metabolic status of a chronic alcoholic is high NADH-NAD ratio. This was asked once in NEET PG. Yeah, the metabolic status of a chronic alcoholic is high NADH-NAD ratio, and this gets translated as high ATP-ADP ratio. Yes or no? When NADH enters into electron transport chain, it gets converted to ATP. So a chronic alcoholic is always in a high energy status. Yeah, when the energy status of the person is high, will the person feel hungry? No. So the person skips meals often. Do you understand this? And when the person skips meals often, then the person becomes prone to develop hypoglycemia. One reason. The other reason is when there is high NADH-NAD ratio, what will happen to the equilibrium between pyruvate and lactate? Whenever there is high NADH, your body will always try to convert pyruvate to lactate. Because during the conversion of pyruvate to lactate, NADH can become NAD. So when there is high NADH-NAD ratio in a chronic alcoholic, all pyruvate will become lactate and all oxaloacetate will become malate. Because in citric acid cycle, you must have learnt that when malate becomes oxaloacetate, you get NADH. When there is high NADH, all the NADH will be used and all oxaloacetate will be converted to malate. So in a chronic alcoholic, because of high NADH-NAD ratio, there is low pyruvate and low oxaloacetate. And as I told you, pyruvate and oxaloacetate are the first and the second intermediates of gluconeogenesis. Without these two intermediates, gluconeogenesis is suppressed. And without gluconeogenesis, there is hypoglycemia. Is that clear to all of you? Yeah, yes, meningococcus. That also causes lactic acidosis. So are you clear so far? So let's look at these choices now. What is the explanation for hypoglycemia? It is not thiamine deficiency. It is because of high NADH, not because of high NAD. It is because of low pyruvate and low oxaloacetate. So the answer is choice C. Okay, so I'm going to tell you about other effects of alcoholism. What are the other effects of alcoholism? As I was telling you, when the energy status of the person is very high, the person skips meals and the person often misses his mixed balanced diet, and that causes essential micronutrient deficiencies. And this is why you call alcohol as a source of an empty calorie. Why am I saying it as a source of an empty calorie? Because it provides more NADH, because it provides more ATP, so it provides more calories. But why am I saying empty calorie? There is no micronutrient. Have you ever seen vodka being fortified with vitamins? Yeah, gin fortified with vitamin D. No, right? We have not fortified any alcohol so far, and it's very difficult to fortify alcohol also, and that is why alcohol is a source of an empty calorie. Got it? Yes. So that is why they are prone to develop essential micronutrient deficiencies, and of all the micronutrients, the first micronutrient to become deficient will be thiamine. Why thiamine deficiency is more common? It is because alcohol interferes with thiamine absorption, and alcohol interferes with magnesium absorption. So what is the relevance of magnesium absorption getting affected in thiamine deficiency? What is the coenzyme role of thiamine? The coenzyme form of thiamine is thiamine pyrophosphate. So for any thiamine that is present in the system to become the active coenzyme form, you need thiamine kinases, and these thiamine kinases need magnesium. Alcohol interferes with magnesium absorption, so even if there is thiamine, it cannot be converted to the coenzyme form of thiamine. So which micronutrient is very yeah, I can see that all of you are laughing. Yes. So I am happy that so far alcohol has not been fortified. At least that fear will be there in those who consume alcohol. Okay. So so what was I telling you? So they are prone to develop essential micronutrient deficiencies. Out of all these micronutrients, which micronutrient deficiency is more common? It is thiamine deficiency, which is more common. And whenever there is thiamine deficiency, do you all know that neurons get affected more? Yeah, neurons get affected more. That is why thiamine deficiency causes dry beriberi. If you want to know why, it is because what is the preferred fuel for your neurons? All your neurons preferably utilize glucose. And how do they use glucose? Because neurons have mitochondria, they use glucose aerobically. What do you mean by aerobic utilization of glucose? Glucose will become pyruvate. If it is anaerobic metabolism, pyruvate will become lactate. If it's aerobic metabolism, as which happens in neuron, pyruvate should be converted to acetyl-CoA, and then this acetyl-CoA will enter into citric acid cycle. And for pyruvate to be converted to acetyl-CoA, which enzyme do you want? You want pyruvate dehydrogenase complex, which is dependent on thiamine. I hope you all remember this. I've told you this so many times. Thiamine pyrophosphate is necessary as a coenzyme for pyruvate dehydrogenase complex. So whenever there is thiamine deficiency, aerobic utilization of glucose gets affected. So neurons get affected more. Though all neurons are susceptible to effects of thiamine deficiency, certain parts of your brain are more susceptible to thiamine deficiency manifestations. Those parts include mammillary body. Yeah, mammillary body is affected. 3, 4, 6 cranial nerves get affected. Cerebellar neurons get affected more. When mammillary body gets affected, do you all remember mammillary body is a part of Papper circuit? And Papper circuit is related to processing memory. And when processing memory or processing information gets affected, that causes global confusion. Yeah, that causes global confusion. When 3, 4, 6 cranial nerves get affected, that causes ophthalmoplegia. And when cerebellar neurons get affected, that causes ataxia. So GOA, what is GOA? GOA. What does GOA stand for here? GOA is a mnemonic that you can remember, that you can use to remember the manifestations of Wernicke's encephalopathy. So what are the facts that you have learnt about Wernicke's encephalopathy? Wernicke's encephalopathy is acute thiamine deficiency. Please don't get confused here. Acute thiamine deficiency is Wernicke's encephalopathy. Chronic thiamine deficiency is Korsakoff syndrome. And Wernicke's encephalopathy presents as GOA. What does GOA stand for? Global confusion, ophthalmoplegia and ataxia. Okay, so that's about thiamine deficiency. And not only thiamine deficiency, they are prone to develop B12 and folate deficiency. When B12 and folate are deficient, that causes macrocytic anemia. So tell me, what is the hematological finding in a chronic alcoholic? It is macrocytic anemia. Okay, and they are prone to develop lactic acidosis, as meningococcus said. You know the reason, right? Why are they prone to develop lactic acidosis? For 2 reasons. When there is chronic alcoholism in a person, thiamine is deficient, so PDH complex will be inactive. So what accumulates? Pyruvate accumulates. Also in a chronic alcoholic, there is high NADH. So all the pyruvate will be converted to lactate. So that causes lactic acidosis. And they are prone to develop fatty liver changes. Please repeat name of syndrome. Okay. Wernicke's encephalopathy is acute thiamine deficiency. Korsakoff syndrome is chronic thiamine deficiency. Okay, and chronic thiamine deficiency or Korsakoff syndrome presents with retrograde and anterograde amnesia. It presents as retrograde and anterograde amnesia, confabulation or honest lying. Yeah, to fill up the gap, they start building up stories. So it is confabulation or honest lying, and sensory agnosia. And imaging studies will show atrophic changes in the brain. You will see mammillary body atrophy, cerebellar atrophy. That is Korsakoff syndrome. Got it? Rabiha Sheikh. Yeah. So that's all about that question. This is another question again on alcoholism. Okay. But the question is actually not about alcoholism. Read it. A 55-year-old alcoholic was brought to the emergency department by his friends. During the usual hangout at the local bar, he had passed out and they were unable to revive him. On admission, his blood glucose was very low. So hypoglycemia. Which of the following proteins would have no significant activity in this patient? They are not asking you what is the reason for hypoglycemia, what is the relevance of hypoglycemia in a chronic alcoholism. The question here is, in hypoglycemia, which of these proteins will be inactive? So Mr. Bean is answering it as C. Bean, C, glycogen phosphorylase is an enzyme of which pathway? Glycogen phosphorylase is an enzyme of glycogenolysis. In hypoglycemia, your aim is to increase blood glucose. And to increase blood glucose, won't you stimulate glycogenolysis and gluconeogenesis? Can Bean answer? Yeah, you will stimulate glycogenolysis and gluconeogenesis. So in hypoglycemia, for sure, glycogen phosphorylase will be active. So that is the first choice that you should exclude. Okay. Now, how about GLUT1 transporters? Okay, many of you have answered it right. Very good. The answer is glucokinase. But before we start discussing about glucokinase, let me tell you about GLUT transporters. So what are the GLUT transporters that you have learnt about? There are 5 GLUT transporters, GLUT1 till GLUT5. So all of you answer this. GLUT1, no, A and D are not the same, Krishnendu. Hexokinase and glucokinase are totally different. I will tell you the differences between these two enzymes now. Okay. So GLUT1 and GLUT3 transporters, where are they present? Both these are present in those cells for which glucose is indispensable. So what are the cells for which glucose is essential? It is essential for neurons. Just now I said neurons use glucose. And then RBCs can use only glucose, and placenta. Okay, so GLUT1 and GLUT3 transporters are present in those cells for which glucose is indispensable. So it is present in neurons, RBCs and placenta. In that case, can you tell me about the affinity of GLUT1 and GLUT3 transporters to glucose? Yes, insulin independent, you're right. So GLUT1 and GLUT3 transporters, tell me, what do you think about its affinity for glucose? Its affinity should be very high. Only then, even when there is low glucose, neurons, RBCs and placenta will be able to use plasma glucose. Because the affinity is very high, even when the plasma glucose is very low, they are going to be active. Do you understand this? Even when there is low plasma glucose, GLUT1 and GLUT3 transporters will be active. Now, how about GLUT2 transporters? GLUT2 transporters are present in those cells which are related to glucose balance. What are the cells which are related to glucose balance? It is present in enterocytes, hepatocytes, pancreatic beta cells and renal tubular cells, because glucose has to be first absorbed along the intestine. It should be stored by hepatocytes. Beta cells should release insulin and renal tubular cells should reabsorb glucose. So all those cells which are related to glucose homeostasis, what are the cells? Enterocytes, hepatocytes, pancreatic beta cells and renal tubular cells, and all these places you have GLUT2 transporters. And GLUT2 transporter, because it's a one which is present in liver and pancreatic beta cell, it exhibits very low affinity. Yeah, it exhibits very low affinity for glucose and it exhibits very high Km for glucose. Got it? So that's about GLUT1, GLUT2 and GLUT3 transporters. So tell me about GLUT4 transporters. Very good. Yes, it is active in the fed state. GLUT2 is active in the fed state. Now GLUT4 transporter, everybody should be able to answer this any time you are asked. GLUT4. Insulin dependent glucose uptake happens in skeletal muscle, cardiac muscle and adipose tissue by GLUT4 transporter upregulation. Is that clear? Insulin dependent glucose uptake happens in skeletal muscle, cardiac muscle and adipose tissue by GLUT4 transporter upregulation, because your body knows insulin is an anabolic hormone and your body knows if it facilitates glucose uptake in skeletal muscle and cardiac muscle, that glucose will be used for glycogen synthesis, which is anabolic. When the same glucose is taken up by adipose tissue, that glucose will be stored as fat. Okay, that is why insulin causes glucose uptake in skeletal muscle, cardiac muscle and adipose tissue by GLUT4 transporter upregulation. GLUT5 transporter is related to fructose absorption and it is present in enterocytes. Are you clear about all of this? Yeah, anytime you ask, you should be able to answer about this tabular column. Okay, so that's about GLUT transporters. Now tell me about this question. In hypoglycemia, will GLUT1 be active or inactive? Even in hypoglycemia, GLUT1 has to be active. Only then neurons and RBCs and placenta will be able to take up glucose. So we have cancelled choice C, we have removed choice B, we have excluded choice C, excluded choice B, and we are left with hexokinase and glucokinase. So Krishnendu, listen to this. I am now going to tell you the differences between hexokinase and glucokinase. Okay. So what is the primary function of both these enzymes? They have one common function. Their function is to convert glucose into glucose 6-phosphate. Thereby they trap glucose within the cell. Do you understand this? Their main aim is to trap glucose within the cell. Okay. Now, the differences between these two enzymes. The first difference is based on location. Hexokinase is present in all cells, but glucokinase is present in liver and in pancreatic beta cells. Please memorize as and when I tell you a fact. Hexokinase is present in all cells, but glucokinase is present in liver and pancreatic beta cells. Second difference is based on Km and affinity. Okay, so for want of time, I am not going to get into the details of Km. All that I want you to remember about Km is Michaelis constant. Yeah, Km is Michaelis constant, and Km is nothing but the substrate concentration at half maximal velocity. Please memorize this. What is Km? Km is a substrate concentration at half maximal velocity. If Km is low, it means affinity is high. Km and affinity are inversely proportional. Do you understand this? If Km is low, it means affinity is high. So now about Km and affinity of hexokinase and glucokinase. Glucokinase enzyme, which I told you is present in liver and pancreatic beta cells, exhibits lower affinity or higher Km for glucose. Glucokinase exhibits lower affinity or higher Km for glucose. Why? Why do you want an enzyme with lower affinity to be there in the liver? Because liver is the first organ to meet any dietary glucose. Yes or no? Any carbohydrate rich diet which you consume gets digested in the intestine, gets absorbed as glucose into portal vein. Through portal vein it reaches the liver first. So which organ in your body meets the dietary glucose first? It is liver. So just tell me what would have happened if nature had provided your liver with an enzyme with higher affinity for glucose. In that scenario, liver would have used all dietary glucose for its own, so that peripheral tissues suffer from hypoglycemia. Do you want that to happen? No. So what kind of an enzyme should be present in liver? An enzyme which can act on glucose only when the glucose concentration is more than what is required for peripheral tissues. Only when there is excess glucose, liver should act on the excess glucose, convert that glucose into glycogen. Otherwise, any glucose that is available should be given off to peripheral tissues for whom glucose is indispensable. Do you understand this? That is why an enzyme with lower affinity is present in liver. Now, why do you want an enzyme with lower affinity in pancreatic beta cells? Because in pancreatic beta cell, it is related to insulin secretion. So, what is the sequence of event which leads on to insulin secretion in beta cells? Glucose enters into beta cell. Glucose goes through glycolysis. Glucose enters into citric acid cycle. As a result of glycolysis and citric acid cycle, you get ATP. And this ATP closes ATP sensitive potassium channels. When you close potassium channels, because beta cells have a special type of potassium channel which closes only in the presence of ATP. So when ATP is produced because of glucose entry into beta cell, potassium channels close. And this potassium channel closure causes depolarization and action potential. This action potential opens voltage gated calcium channels. Calcium ions enter into beta cells and that will cause insulin release. So have you understood the sequence of events which finally result in insulin release? It all starts with glucose entry into beta cells, glucose entering into glycolysis and citric acid cycle. ATP is produced, ATP closes potassium channels, opens calcium channel, that causes insulin release. Now imagine, what would have happened if beta cells are provided with an enzyme with higher affinity for glucose. If the enzyme here has got higher affinity for glucose, then this sequence of event will happen even when there is low glucose. And even when there is low glucose, insulin will be released. And that insulin will aggravate hypoglycemia. Do you want that to happen? No. You want insulin to be released only when there is hyperglycemia. So what kind of an enzyme should be there in beta cell? Only an enzyme which can act on glucose when the glucose concentration is very high. So the affinity here has to be very low. Got it? So have you understood these two differences between hexokinase and glucokinase? The first difference is hexokinase is present in all cells, but glucokinase is present in liver and pancreatic beta cells. Second difference is glucokinase has got lower affinity or higher Km for glucose, whereas hexokinase has got higher affinity or lower Km for glucose. Okay. Third difference is inhibition by the product. What is the product? The product is glucose 6-phosphate. Hexokinase is inhibited by its product glucose 6-phosphate. Do you understand this? Hexokinase is inhibited by its product glucose 6-phosphate. And this is true for almost all the enzymes. You take most of the enzymes, they get inhibited by their products. For simple reason, when you have enough products, you don't want to waste the substrates and coenzymes for synthesizing the same. So almost all enzymes get inhibited by their products, and hexokinase is also inhibited by the product, which is glucose 6-phosphate. But glucokinase is not inhibited by glucose 6-phosphate. Why do you think glucokinase should not be inhibited by glucose 6-phosphate? It is because already you said that this enzyme glucokinase should be active only when the glucose concentration is high. And even at that point of time, if you are going to say that this enzyme gets inhibited by its product, then at no point of time the enzyme can be active. You can be stringent on an enzyme either from the substrate side or from the product side. You cannot have bottlenecks on both the sides. Do you understand this? You cannot have bottlenecks on both the sides. So already you are stringent on glucokinase, stating that you have to be active only when the glucose concentration is high. In that case, if you are going to allow this enzyme to be inhibited by its product, then at no point of time the enzyme can be active. That is why glucokinase is not inhibited by glucose 6-phosphate. Okay. The last difference between hexokinase and glucokinase is induction by insulin. Yeah, induction by insulin. Glucokinase is inducible by insulin, but hexokinase is not. Yeah, glucokinase is inducible by insulin, but hexokinase is not. So why should you know this? Yeah, what is the reason behind this? When did I tell you glucokinase will be active? Glucokinase will be active only when the glucose concentration is high. And what is the signal for high glucose? It is insulin. So that insulin should induce glucokinase, but insulin need not induce hexokinase. Okay, so that's all about differences between hexokinase and glucokinase. So now do you understand that for every fact that you learn in medicine, when I say medicine, in the whole medical curriculum, it can be anatomy, physiology, biochemistry, any subject. Yeah, for any fact that you learn in medical curriculum, there is always a reason behind it. My humble request to all of you is to find out the reason behind the fact that you are learning. If you know the reason, you will be able to apply the fact that you learn, because we are in an era of knowledge, right? The knowledge is overloaded everywhere. So it's not sufficient if you know that glucokinase is not inhibited by glucose 6-phosphate. It's not sufficient if you know that glucokinase is present in liver and pancreatic beta cells. Anybody who can browse will know these facts. But you as a medical person should know why this difference has existed at all. Okay, so only that way you will be able to apply any fact or any concept that you learn. Okay, so that's about differences between hexokinase and glucokinase. So can you answer this question now? This person is hypoglycemic. In a hypoglycemic person, which enzyme will not be active? In a hypoglycemic person, glucokinase will not be active, because I kept repeatedly telling you glucokinase will be active only when the glucose concentration is higher. Okay, so answer is choice A. Okay, yes. So let's have this question as the last question for tonight. The process of gene regulation involves condensation and uncondensation of chromosomes. This process occurs by binding of a variety of proteins on DNA by charge interactions. At physiological pH, the charge on DNA is, what is the right answer? What charge does DNA carry? You forget about all these facts. I'll tell you about all these facts now. Okay, but what is the charge DNA has? What is DNA? One double-stranded DNA. Yes, it is negatively charged because double-stranded DNA will have multiple phosphate groups, and all these phosphate groups are negatively charged. Okay, so answer is choice B. But why should you know all these facts? For you to understand about chromosome condensation and uncondensation. So what is chromosome? Whenever you say a chromosome, whenever you talk about a chromosome with a centromere, with a short arm and a long arm, I want you to remember that this chromosome is nothing but a long double-stranded DNA which has got condensed with the help of proteins. What is one chromosome? One chromosome is nothing but one long double-stranded DNA which has got condensed with the help of proteins. Now tell me, why should you condense your long double-stranded DNA into a compact chromosome? It is because if you uncondense every chromosome into a long double-stranded DNA, it is going to measure a few meters long. Okay, can you pack such a chromosome which is few meters long inside a nucleus which is few microns in diameter? You cannot. That is why you are going to condense it. And how do you condense it? It is condensed with the help of histones. So what are histones? Histones are basic proteins. When I say they are basic, I mean to say they are positively charged. Acids are negatively charged, bases are positively charged. So histones are positively charged and their DNA is negatively charged. So there is an electrostatic attraction between positively charged histones on one hand and negatively charged DNA on the other hand. So that a segment of double-stranded DNA gets wound around histones. So that a segment of double-stranded DNA gets wound around histones, and this gives the first level of compactness to your chromosome. Do you all understand this? This gives the first level of compactness to your chromosome. So how many types of histones do we have? We have 5 types of histones: H1, H2A, 2B, 3, 4 and 5. There are 5 types of histones: H1, 2A, 2B, 3, 4 and 5, and they help in condensation of chromosome. Okay, so that's about condensation of chromosome. Now what is the next question? Nucleosome. I think I've already told you about nucleosome. I think you can watch part 2 of Biochem Pearls to understand about condensation of chromosome. Okay, so try to answer this. Bar body is an example of euchromatin, constitutive heterochromatin, facultative heterochromatin, hypersensitive heterochromatin. What is the right answer? Bar body is an example of facultative heterochromatin. Okay, so let me tell you about types of chromatin. There are 2 types of chromatin. One is euchromatin, the other one is heterochromatin. Euchromatin is transcriptionally active region of your chromosome. When I say it is transcriptionally active, will it be condensed or uncondensed? I said to enable package. To enable package, I said the chromosomes will be condensed. But when your chromosomes have to perform their functions of replication and transcription, all your chromosomes, all your double-stranded DNAs can do only 2 functions. Okay, one is replication, the other one is transcription. So when your chromosomes need not perform any of their functions, to enable package they will be highly condensed. But whenever they have to perform their functions of replication and transcription, they will be uncondensed. So when I say euchromatin is transcriptionally active region of chromosome, will it be condensed or uncondensed? It is going to be uncondensed. When I say it is uncondensed, will it stain more densely or less densely? Uncondensed part will stain less densely. Exactly opposite of this is heterochromatin. Heterochromatin is transcriptionally inactive region of a chromosome. When it is transcriptionally inactive, to enable package, it is going to be highly condensed. When it is highly condensed, it stains more densely. Okay, that is why whenever you see GMSA staining of a chromosome, G-banded chromosome, you will see alternating dark and light bands. So what do those dark bands represent? Dark bands means they are highly condensed. When they are highly condensed, it means they are inactive. It means it is heterochromatin. Do you understand this? Whereas if it's lightly stained, it means it is uncondensed, it means it is active part of the chromosome. Okay. Now this heterochromatin is of two types. One is constitutive heterochromatin, the other one is facultative heterochromatin. What is constitutive heterochromatin? It is transcriptionally inactive always. You take any chromosome, in all the 46 chromosomes, there are few regions which are always inactive. So what are those regions? Constitutive heterochromatin, which are inactive always. One is centromere, the other one is telomeric ends. Do you understand this? Centromere and telomeric ends come under constitutive heterochromatin type. Why? It is because, do you know that in M phase, there is a phase called as metaphase. Yeah, in mitosis, there is a phase called as metaphase, and in metaphase, mitotic spindle is formed and it gets attached to the centromere. And in anaphase, when the mitotic spindle contracts, the centromere breaks longitudinally. Yeah, during anaphase, when the mitotic spindle contracts, the centromere breaks longitudinally. One long arm and one short arm goes to one pole, the other long arm and the other short arm goes to the other pole. This means your centromeric region is subjected to repeated breakage. And breakage will never be perfect. There will be always a tendency for one chromosome to gain some of the sequences and the other chromosome to miss some of the sequences. So tell me, what would have happened if nature had provided a centromeric region with something which is coding? It means following every M phase, following every mitosis, following every cell division, when you get two daughter cells, one daughter cell would have undergone duplication of gene sequences, the other one would have undergone deletion of gene sequences, both of which are detrimental. Right? And only to avoid that, centromeric regions have evolved in a chromosome in such a way that they have transcriptionally inactive parts. So constitutive heterochromatin is present in centromeric region and in the telomeric parts. Facultative heterochromatin, the best example is female X chromosome. Okay, you know that both, though all somatic cells of females, all females have two X chromosomes, only one of the two X chromosomes is transcriptionally active, the other one is transcriptionally inactive, so it is highly condensed. And it is highly condensed, so it stains more densely as bar body. So what is bar body? Actually, it is inactivated X chromosome which is highly condensed, which stains more densely. And that is why bar body is a heterochromatin. But why is it facultative heterochromatin? Because it is inactive only in somatic cells, it is active in germ cells. Do you understand this? Inactive only in somatic cells, it's active in germ cells. So what is the best example for facultative heterochromatin? It is female X chromosome or bar body. Are you clear about this? Yeah, so what is the right answer here? Bar body is an example of, yes. When I say females, whenever there is more than one X chromosome. Yeah, whenever there is more than one X chromosome, the other one will be inactivated. So bar body is an example of facultative heterochromatin. Example for constitutive heterochromatin will be centromere and telomeric ends. Okay. So that's all for today. I will see you soon with another session. Probably tomorrow or day after tomorrow we'll have another session which will be Biochem Pearl part 6. Okay. Thank you, Mr. Bean. Have a good night.